Well, welcome everyone. Have a really good group here. And today speaking for us is Dr. Sethu. He's a professor in the Department of Medicine in the Division of Cardiovascular Disease. He received his Ph.D. in Biomedical Engineering from the University of Michigan. I think that was about 2002, if I'm not mistaken. Okay. Did postdoc at Harvard Medical School, Massachusetts General, and also Shriners Burn Hospital, which I think is in Galveston, if I'm not mistaken. Oh, it's in Boston too. Okay, came to UAB as an associate professor in 2013. Over the years, has had various academic appointments, including directing medicine, engineering, education, serving as section chief for cardiology research, attaining professorships, of course, in both biomedical engineering and medicine. Recently received one of the Department of Medicine's Unsung Hero Awards. Extremely active in mentorship at all levels. So he served on numerous thesis committees for master's and PhD students. Has a large list of students on his CV that he's mentored to success with several in recent years, receiving NIH-sponsored cardiovascular fellowships. And also, I was impressed looking through his CV. He's made a lot of effort over the years to impact students before the college level. There's a really long list of high school students that he's worked with that he's mentored through being naturally involved in different symposia and science fairs and things like that, which I think is really neat and important. Also serves as the PI in several NIH and NSF grants. Major research interests revolve around the engineering of substrate models for culture of cardiac and vascular cells in vitro. So really working toward trying to mimic sort of the in vivo state for research and clinical purposes. Going to be talking today on the role of loss of pulsatility in the development of non-surgical bleeding and left ventricular assist device patients. Welcome, Dr. Sethu.
So thank you so much for that introduction and having me here at the pathology grand rounds. I don't think I've ever done pathology grand rounds. I've been here for 10 years now. So it's good to be here. So, all right. So I am a biomedical engineer by training. So my lab has primary expertise in engineering design and biomaterials. We combine this with our knowledge of human anatomy and physiology to do what we call human cell and tissue engineering. We use this to build what NIH like to call a tissue chip model of various organs and tissues in the body. My lab is primarily focused on the blood vessels in the heart. We also do some work with the liver and the kidneys. So you can get these tissue chip models to start to communicate with each other and build more complex microphysiological systems. This is our long-term goal, but for the purpose of today's talk, I'll be talking about our vascular tissue chips and how we're using that in the context of left ventricular assist devices. So I'm not going to talk about our cardiac tissue chips, but I'll just show you one slide with what we do with these cardiac tissue chips. So what you see in that picture is a strip of cardiac tissue that we engineered in the lab. Those are made using human-induced pluripotent stem cells. We put them within these type of platforms, and what we're able to do is subject them to pressure volume loading associated with the left ventricle. So we're able to mimic changes in pressure and stretch associated with the cardiac cycle. And the reason why this might be important is because the heart is in an environment which is similar to this, and almost every disease state associated with the heart is associated with changes in levels of pressure and stretch. So this model can really mimic that. I won't talk more about this, but today's talk is going to be focused more on our vascular tissue chips and how we use this in the context of left ventricular assist device space. So before I begin, I just want to kind of say this up front. It was very difficult for me to put this talk together because usually you want to have something where you have a defined hypothesis and you generate data in support of that hypothesis, and you're somewhere between your end goal and where you started, and you are putting all this data out in a linear fashion. But this project has kind of taken us through many different turns. We've had to adjust our hypothesis on many different occasions based on study section feedback and based on literature that was published when we started doing things. So actually, it was very confusing for me initially. I've tried to make this as simple as possible, but bear with me if it's confusing. So we're going to be talking about our vascular tissue chips in the context of left ventricular assist devices. So these devices are standard therapy for patients with advanced heart failure that are not responsive to medications. Initially, when they started developing these devices, there's two types of devices. One is the pulse stop flow pumps, and the other the continuous flow pump. So these were essentially to replace heart function. So if you have a failing heart, they put you on one of these pumps until you get a transplant heart. Now they start using these for vaccination therapy as well. So the continuous flow VADs, there was a huge debate initially, but then I think the community settled on continuous flow VADs, and almost all the VADs that were put in patients past 2000 are continuous flow VADs. They have several advantages that are listed there, but the key thing I want to point out is when you get a continuous flow VAD, then you go from this normal pulsatile flow that you see in monthly arteries to this non-physiological flow, which is not completely continuous, but continuous for the most part. When you think about that, you think that these are life-saving technologies, but they're greatly underutilized. So this is actually a circulation paper from 2010 that looks at theoretically the number of candidates eligible for LVAD therapy. Could be about 300,000, probably greater now. But based on the current reported procedures, which are on the far right, this number, based on those criteria, is lower, closer to 60,000. But still, we put in less than 9,000 VADs in patients each year. One is it's a very expensive device. It also requires major surgery. So not a lot of people have the insurance and they don't want to go through the surgery. But there's also other things that are important. There are several factors that affect a quality of life when you get these VADs. So there's VAD-related adverse events. The main one of these is bleeding. This particularly happens in the GI tract, and you also have a lot of heterogeneous malformations. This is like the major reason why these patients get admitted to the hospital again after getting a VAD. And I think the number is about 50% after 1 year. 50% of these patients have to get readmitted to the hospital. The other complication is thromboembolic events. This mainly relates to cerebrovascular and ischemic events. And then you also have to deal with infections with any surgery, aortic insufficiency and right heart failure, which are not as significant as the first two. So thrombosis and bleeding are really two ends of the spectrum. There are several factors that put these VAD patients at risk for bleeding. We'll go into those in detail a little later. But once the VAD is implanted, the first thing that happens is these patients are put on anticoagulant and antiplatelet therapies, which predisposes them to bleeding. And then once they start bleeding, the way clinicians respond to this is by reducing the anticoagulation and antiplatelet therapy, and now there are increased risks for strokes and thrombotic events. So there's a fine balance between managing these patients, and really the challenge is how can we prevent bleeding in the first place? Those other factors that contribute to bleeding, so we don't have to reduce anticoagulant and antiplatelet therapies. So just some introduction, there's examples of VADs prior to 2022. If you were to look at the VADs available in like 2021, 2022 early, these were the three devices that were available. It's the HeartMate 2, the HACE-VAD, and the HeartMate 3. HeartMate 3 is a newer version, the advanced version of HeartMate 2. But in 2022, both these devices went on the market, and now we're left with one FDA-approved device for these patients. So just looking at HeartMate 3, this is what they call a centrifugal pump. And if you look at the blood flow, get a laser pointer. So the blood flows in through here, and there's a centrifugal rotor that is constantly rotating, and that pumps blood into the aorta. So the design improvements that they were talking about is the blood flow paths were widened significantly. And this is to reduce shear stress, because shear stress was thought to be a major factor in bleeding. Also, this is a newer device with these frictionless bearings. So these are magnetically levitated, so you don't have to deal with device failure due to failure of the bearing. And then they developed something that they call an intrinsic pulse. So you can change the speed of the pump periodically. So there's a sudden increase in the speed of the pump, and it introduces mild pulsatility, but this is very different from physiological pulsatility. And the reason they did this was not to restore pulsatility, but more to prevent stasis. So there's blood stagnation within certain locations in the ventricle. So by doing this, they were able to wash the ventricle better. So all these design improvements were made. And then when you start to look at adverse events, particularly in the context of thrombosis and bleeding, what I want you to focus on is here, 0 to 2 year incidence, HeartMate 2 versus HeartMate 3, they were able to significantly reduce the amount of bleeding from 18% to 2%, or less than 2%. And when you look at the 2 to 5 year instances, again, 17.9 to 3.8, so they made a big impact by widening those slope paths to minimize the thrombotic events. But so if you minimize thrombotic events, you also minimize the occurrence of stroke. But if you look at the bleeding, they were able to make a small difference, but not a significant difference. The 5 year and the 2 year. So in summary, with these improvements that they made to HeartMate 3, they've seen improved 1 and 5 year survival rates, significant reduction in pump thrombosis, but the incidence of bleeding still remains. So if you go back and look at this literature over 20 years now, there's a strong correlation between the loss of pulsatility and bleeding, but the mechanisms are very poorly understood. And this is what we're focused on over the last 10 years or so. So we think that this is a complex problem. We initially thought that endothelial dysfunction was a major issue, but we submitted several grants, and every time the study section comes back to us and says, you're looking at a small part of this very complex multifactorial problem. So we acknowledge that, and then we try to look at different factors that could make this a complex multifactorial problem. So there's endothelial dysfunction, there's von Willebrand factor, there's alterations in von Willebrand factor homeostasis, and then there's also platelet dysfunction. So there's two factors that one, the literature believes is very significant, that's turbulence, and then one which we think is more significant than that, which is loss of pulsatility. So today's talk is going to focus on the loss of pulsatility, how that contributes to dysregulation of BWF homeostasis and endothelial. So if we think loss of pulsatility is a major issue, then what are the ways that we can address that issue in these patients? We can either go back to pulsatile flow VADs, which were developed almost 20 years ago, and then nobody bothered about them. But that's not going to happen because all of these companies that make these devices have made significant investments in the continuous flow technology. But we can use this continuous flow technology to reintroduce pulsatility. The way you do this is we change pump speed rapidly. So you can have the pump spin faster and slower, and then reintroduce pulsatility. But you cannot go back to normal pulsatility, which is 120/80 with a pulse pressure of 40 millimeters of mercury. That's because these VADs have peak flow rates that are much lower than your native ventricle. So you can reintroduce pulsatility, but it'll have to be at the expense of pulse frequency or pulse pressure. So you can maintain normal heart rate 80 beats per minute and get the pulsatility back up to like 20 millimeters, pulse pressure back up to 20 millimeters of mercury, or you can not care about the pulse frequency, get back to 40 millimeters of mercury pulse pressure, but a much lower frequency. So if you're going to test all of this, you need models. So small animal models, nobody makes VADs for these small animals. These don't emulate human heart cardiovascular disease, at least in the context of that. There's large animal models, mostly pig and calf models. These are used mostly for testing device safety, reliability, and biocompatibility, but they're inadequate to model the effects of diminished pulsatility because the non-surgical bleeds that you see in these patients, Asian heart failure patients, you can't reproduce with these young animals. So we looked at the models we had, and then we had to come up with fine-tuning our models to address this issue. We looked at where the effects of pulsatility were significant. And this is in the arteries, where you see this nice pulsed-out flow and pulse pressure associated with that pulsed-out flow. So we have endothelial cell culture device. So this is just a flow channel. If you flip this on the side and cut it and look at the section, at the bottom is a thin membrane. So these endothelial cells are cultured on this thin membrane, which is flexible. So when we introduce pulsed-out flow into these devices, we could reproduce the pressure, the shear stress associated with the flow, and the stretch that these see in the arteries. Now, by culturing patient-derived human aortic endothelial cells in here, we believe we have a really good model of human arteries. So we take this device, we incorporate it within flow loops. So these are mock flow loops, which contain the cell culture device. There's a pressure sensor, it's a flow sensor, and we have compliance element and a resistance element. By modulating these, we can change the waveforms into exactly what we want. So we're able to mimic normal pulse style flow. So maybe. So these beads are just helping you visualize what the flow looks like. So the particular thing I want you to pay attention to is there's acceleration in the flow and then it decelerates and stops. But before it stops, you see this little point where the beads oscillate. So that's mimicking what happens when the aortic valve shuts and the flow bounces back off a bit. So using our model, we could reproduce normal pulse style flow and flow associated with continuous flow ventricular assisted basis. So this is not completely continuous. You see a little bit of pulsatility. That's because your heart is still beating when you have these VADs. So that's the residual pulsatility in here. So this is pressure, flow, and stretch waveforms. And we were able to normalize mean flow pressure and mean change the shape of the wave. So once we had these waveforms ready, we had the cell culture model ready, we needed to validate our models to make sure they model human arteries. So we published a paper in 2016 where we took aortic tissue from these LVAD patients before they got the VAD. So their arteries or aorta is experienced only pulse style flow to that point. And then we also got aortic tissue from these patients immediately after they got a heart transplant. So this is tissue that's experienced continuous flow from that point forward. So we compared this to normal pulse style flow and LVAD flow within our devices. We were able to show that the endothelial dysfunction that we saw in the patients was accurately mimicked in our devices. So we had a model which we were confident was going to model LVAD flow phenomena. I didn't put any of the data in here because that'll take up a lot of time. I've got more data to show. So just take my word for it. We were able to show endothelial dysfunction. And if you want, you can look at the paper. So now we got a model. Now we designed these flow modulation protocols where we get normal pulse style flow and continuous flow, which we've already done. And then the synchronous flow modulation where we preserve the pulse frequency, but the pulse pressure, we can't get it up to 120 over 80. We can only go maybe 105 over 90. And then the second condition was pulse pressure back up, but the pulse frequency is much lower than the other condition. So we published a paper again. I'm not going to go through the data, but what this suggested was the pulse pressure rather than pulse frequency is critical in preventing endothelial dysfunction. So the 40 millimeters of mercury at 40 beats per minute was much better than the 20 millimeters of mercury at 80 beats per minute. So it looks like pulse pressure is very important. So we were looking at endothelial cells. We took the endothelial cells, we lysed them, we looked at gene expression, we looked at protein expression. But that's not really a feasible way to test these protocols in patients. In patients, you want something that you could sample easily, which is something that's in blood. So then we looked at what happens to these arterial endothelial cells that become dysfunctional. They become dysfunctional, they probably produce soluble factors that are pro-inflammatory, pro-angiogenic, which contribute to the GI bleeds. And this gets carried in the blood flow downstream to the microvasculature, where the complications like GI bleeds and AVMs happen. So we took the media from our cell culture experiment, and then we did 2 multiplex ELISA panels, one to look at pro-angiogenic factors, one to look at pro-inflammatory factors. And we found changes in significant number of these, including angiopoietin 2. And angiopoietin 2, I'll keep coming back to that. That seems to be the most consistent of the lot. So then what we were able to do is collect patient samples over a period of time and look at what changes in these patient samples before the control is pre-VAD blood samples and then the 1 month, 2 month, 3 month follow-up blood sample. So the first one here is von Willebrand factor. It seems like there's a significant decrease in von Willebrand factor, and that stays down over time. Then the other markers with these patient samples, it's very difficult to get anything consistently, especially because these patients are heart failure patients on different types of medications, different types of comorbidities. So angiopoietin 2, for some reason, always showed up. The other markers are IL-6, IL-8, and BNF that showed significance. So then we compared this to our in vitro model. Within our in vitro model, we were able to show that decrease in the von Willebrand factor production and the elevation in the angiopoietin 2 production, not with any of the others. So we started to focus on these two as markers to potentially evaluate flow modulation protocols in patients. So this is just 1 month, most of these are just 1 month after the one-year effect is up to 3 months, and the sample size is pretty small. So this IRB protocol has been in place for almost 2 years or 3 years now. We've got a significant number of patient samples, and we're able to go out up to 6 months. So when we look at longer term outcomes with angiopoietin-2, it looks like the elevation in angiopoietin-2 is not sustained. It goes up a little bit and then falls off in most of these patients. This is 15 patients looking at them up to 6 months. What was interesting was when we look at patients that bleed versus patients that don't bleed, it looks like that elevation in the angiopoietin-2 level after 1 month was mostly in those patients that bled and not in the patients that did not bleed. So this is just looking at ELISAs. We confirmed this with Western blots, where we looked at free angiopoietin-2 and bound angiopoietin-2. And you see in the patients that don't bleed, there was no elevation in the free angiopoietin-2 or the bound angiopoietin-2. But in the ones that bled, there was this initial increase and then that dropped off. So for the two markers that kept popping up, one molecular factor and angiopoietin-2, we looked at literature to see if anybody else has looked at both of those and if they behaved cooperatively in some way. Practically. I skipped a little bit. I'll go through a couple of our other studies, and then I'll get to that point. So we took the plasma from these patients. We did the endothelial tube formation assay, where we looked at average open area, number of tubes, number of branch points, and we found that with the high angiopoietin-2, this is the bleeders, that tube formation increase, there was more increased angiogenesis, whereas the ones with low angiopoietin-2, the non-bleeders mostly, the tube formation actually decreased when we treated with the plasma. So this is the point where we were looking at angiopoietin-2 and von Willebrand factor. We found this paper, which is pretty interesting. And this actually strengthened the hypothesis because we're trying to make a case that diminished pulsatility or loss of pulsatility is important. So this paper from a group at UPenn, I think at that time, but this guy moved since, is the von Willebrand factor and angiopoietin axis contributes to dysregulated angiogenesis and angiodysplasia. And this was in a particular patient population with patients that have Glenn circulation. So just a brief introduction. So these are patients with congenital heart disease, condition hypoplastic left heart syndrome. So the left ventricle doesn't develop. So the only functional ventricle is the right ventricle. So in order for these patients to survive, what they do is immediately after birth, they take the flow from the inferior superior vena cava and route it through the pulmonary arteries directly to the lungs. So in normal patients, what would happen is the output from the right ventricle goes into the lungs. So there's pulsatility associated with that. But in this case, you're just taking the flow from the venous return and directly sending it to the lungs, where you go from pulsatile flow to continuous flow now. And then the return from the lungs is routed to the right ventricle, and the right ventricle contractions inject the blood into systemic circulation. So what was interesting with these patients was they developed angiogenesis in pulmonary angiogenesis, not angiodysplasia anywhere else, but only in the pulmonary circulation. So this appears to be something that happened because you went from this normal pulsatile flow to continuous flow. And von Willebrand factor angiopoietin-2 levels were abnormal in these children. We think it's possibly due to the fact that this loss of pulsatility contributes to elevated angiopoietin-2 levels, but also, I'll talk about this a little later, but this is where I mean that I can't give you a linear story because I haven't talked about von Willebrand factor degradation yet. But we think it contributes to von Willebrand factor degradation also. So both these, the degraded von Willebrand factor and angiopoietin-2, bind together and cooperatively drive angiodysplasia. So this is everything I've talked about at this point had to do with the endothelial cells and how they become dysfunctional with this change from pulsatile to continuous flow. And we're actually doing some studies right now where we're taking normal plasma, which has intact von Willebrand factor, combining a recombinant angiopoietin-2, and also taking plasma and degrading the von Willebrand factor, breaking into low molecular weight fragments, using it in combination with recombinant angiopoietin-2, trying to do the tube formation assay and look for transcriptional changes that may shed some more light into how they work cooperatively to facilitate angiodysplasia. So now, these patients that have these left ventricular assist devices all have developed a condition called acquired von Willebrand syndrome. So this is where I'm going to fill you in on what happens with von Willebrand factor. So this is just some articles that I picked up. If you look at that literature, the number of patients that have acquired von Willebrand syndrome is anywhere from 90 to 100%. So the improvement to HeartMate 3, this article came out, and reading the title, you may think that this issue has been addressed. But then if you go and look at the details, if you go by the characterization of what acquired von Willebrand syndrome is, which is a decrease up to 30% of the high molecular weight von Willebrand factor, was found in 97% of the older generation device and 100% of the patients with the new, no, 100% of the patients with the older device and 97% of the patients with the new device. So it's a 3% decrease, but it's an improvement, but it's not significant. So it appears that this is not, it still is an issue with the HeartMate 3. So some background on what this acquired von Willebrand factor, von Willebrand syndrome is. So von Willebrand factor, I guess to this audience, I really don't need to explain what that is. It's a plasma glycoprotein, plays a critical role in coagulation. In circulation, it exists as large monomers. So under flowing conditions, this molecule unravels. When it unravels, it exposes atom TS13 cleavage sites. Atom TS13 is a metalloprotease that's available in circulation, binds to those cleavage sites, cleaves this into low molecular weight fragments. So this mechanism is really for when you have an injury and you've started this coagulation cascade to prevent excessive coagulation. The blood flow, when the von Willebrand factor attaches to those sites, then gets unraveled, cleaves into low molecular weight fragments, don't block blood flow. But in these patients that have these left ventricular assist devices, there is excessive von Willebrand factor degradation. And most people in literature, most people in the literature that they published suggest that it's due to supraphysiological shear. So this is extremely high level of shear that you don't see in normal circulation, but you see as blood transits through the device itself. But for us, we were a little skeptical about this because the transit time through these is about 30 to 100 milliseconds, and it may not be sufficient for this unraveling process to take place. So, and also if you look at the locations within this device where you have the supraphysiological shear, it's less than 15% of the device, and with HeartMate 3, it's even less than that. Also, acquired von Willebrand syndrome occurs in these patients with aortic stenosis and with the patients with blood circulation. In both those cases, you don't have a pump, but they're still having acquired von Willebrand syndrome. And the thing that's common between the three conditions is you lost pulsatility. So we were not interested in von Willebrand factor initially because we're interested in pulsatility, and everybody in literature is saying, suggesting that that's due to supraphysiological shear. And supraphysiological shear does not need to be pulsatile. It could be continuous supraphysiological shear, and everybody thought that was what was causing the unraveling and degradation. So what really piqued our interest is this publication that came out in 2018, where they looked at arterial pulsatility and circulating von Willebrand factor in these patients with mechanical circulatory support. And they found a dose response between the level of pulsatility and the amount of von Willebrand factor degradation. And not only did they find that von Willebrand factor was degraded as you lost pulsatility, this is a review article that came right after this because the field got very excited. And they also hypothesized that this loss of pulsatility was contributing to decreased production of von Willebrand factor. So you're producing lower amounts of von Willebrand factor and you're degrading higher amounts of the higher molecular weight von Willebrand factor. So then this got us interested because this then suggested to us that not only is endothelial dysfunction a consequence of loss of pulsatility, but maybe acquired von Willebrand syndrome is also a consequence of loss of pulsatility. So this is really a summary of the paper. What they were able to do and actually would enable this study is this is a swine model, but you have these small catheter-based pumps that you can insert into the ventricle or into the aorta, and then you can pump blood using those pumps. So they use that to introduce continuous flow within the circulation. What they were able to show, and this is their hypothesis, is when you have these continuous flow ventricular assist devices, you increase pump shear. They think it's due to shear, and that causes high molecular weight monomer brain factor degradation. So this is activating monomer brain factor, activating ADAM-DS13, which is the enzyme that cleaves it, and this leads to decreased high molecular weight monomer brain factor patterns. But also the secretion of monomer brain factor is affected. So decrease in arterial pulse, decrease in endothelial secretion of monomer brain factor, and these combined together contribute to non-surgical bleeds. So we're engineered. One of the classes that I took, both the basic version and advanced version I teach is fluid mechanics class. So when somebody tells you that shear is causing something to unravel, you have to think about what shear really is. So if you want, shear really depends on the velocity gradient. So if you have fluid that's just flowing really fast, but when you look at the layer of the fluid, everything is flowing at the same velocity, that's not sufficient to unravel. You actually don't have high shear. You have high velocity, but you don't have high shear. So if a molecule is being pushed by fluid that has the same velocity across the surface area of that molecule is probably not going to unravel. But if you have a velocity gradient, so at one side of the molecule experiences low flow and the other side experiences high flow, now you get a velocity gradient. That's when you have high shear. Now this is what will unravel that molecule. So all of the bad literature with the von Willebrand factor transiting through the pulmon, the von Willebrand factor is in circulation. So it's not attached to the wall of anything. So the shear may not be as significant as they think it is, because all of the calculations are based on what happens to the wall. Because the wall, there's no flow. As you go closer and closer to the middle, you get higher flow, but once you get past a certain point, the velocity is almost a straight line. So everybody's looking at von Willebrand factor that's flowing through a free von Willebrand factor, a soluble von Willebrand factor. And I don't know if the shear is sufficient to unravel those as it transits to the pulmon. But if the von Willebrand factor molecule is attached to the surface, then even a little bit of shear or a little bit of velocity change be a significant amount of fluid, and that's sufficient to unravel this molecule. So this is all based on laminar flow. Then there was a couple of publications that came out that suggested turbulent flow. And this it's probably more fluid mechanics than you want for this talk, but I'll explain this anyway. So they suggested that laminar flow, regardless of how high you claim the shear is not sufficient. Well, let me explain what laminar flow is. Laminar flow is when you have fluid flowing. You can think of a deck of cards and you slide the top card, the bottom card is dragged along with it, and the card below that's dragged along with it. So fluid flowing in layers, it's very organized. And in laminar flow, unless you're at the walls, at the bottom or at the top, the velocity gradient is not very significant. But with turbulent flow, it's very chaotic. With turbulent flow, there is a chance that you have this kind of phenomenon happen. So this made sense to us. Maybe the VAD is inducing us a lot of turbulence, and that's contributing to von Willebrand factor unraveling. But still, the locations where you see this turbulence happen is this very small portion of the VAD, even smaller than the locations where you see supraphysiological shear. And the transit time is very short. And this 30 to 100 milliseconds is for the molecule to transit through the entire device. But to transit through that region of turbulence, it's probably a fraction of that. And this doesn't seem like it's feasible for a molecule to unravel, for ADAM-DS13 to bind at that time and then cleave it into small bits. So we started to explore where this might happen. And then we had to go back and figure out where von Willebrand factor is produced. We're engineers, so we had to go back and figure out from the basics. We had to look at where it's produced, what happens to it after it's produced, where does it end up. So it's produced mostly in endothelial cells. So the production of monovalent brain factor is transcription regulated. Once it's produced, it's packaged in vivo plate bodies, and then those vivo plate bodies fuse with the endothelial cell membrane. The monovalent brain factor that's produced remains anchored to the endothelial surface, requires blood flow or shear to unravel it partially, IMDS13 to cleave it and release it into circulation. So confirmation of that was really reading this paper, where they took endothelial cells, they stimulated them with histamine and then subjected them to flow. And if the flow, the media that they used for the flow experiments, if it did not have IMDS13, it resulted in this formation of these large strings. And the way they're visualizing these strings is by platelet binding to those strings. So the unstimulated ones, there wasn't one brain factor release. Here's some data pulled up. So they counted the number of strings in different types of endothelial cells. And as long as they stimulated histamine and subjected to flow, there were a significant number of strings on these cell surfaces. So one brain factor is being produced, it's being released into circulation, but it's not cleaved from the surface of the endothelial cell. So those strings are essentially one brain factor that's released, but does not have IMDS13 to cleave it to release it. The number of strings is pretty similar for all types of endothelial cells. When they use just a buffer, no IMDS13, the strings remained. They use normal plasma, which has IMDS13, all of them are cleaved. When they use plasma from patients with thrombocytopenic purpura, which is IMDS13 deficiency, the strings remained. And then when they use purified IMDS13, they were released. So we kind of have an idea as to a location in the body, not in the pump, but a location in the body where monovalent brain factor is produced. It's anchored to the wall and it's experiencing shear, which shear causes unraveling. So this may be potentially worth investigating. At that time, a colleague of mine, a former colleague of mine, she published a paper, and I got an email saying she published, and I was looking at it, and she published this paper where they took monovalent brain factor molecules, immobilized them to the surface of a microfluidic channel, and then subjected them to different levels of shear to see how they unravel, and the unraveling lengths, how they correlate to the shear rate. So they were able to show when you increase the shear rate, you're able to unravel these further and further. And we thought this was perfect for us because we wanted to know what happens to monovalent brain factor, not just under flow, but under pulsatile flow. So we asked her to do a bunch of experiments where we gave her different flow conditions, and what she found, this actually very interesting results, is when you have the continuous flow or diminished pulsatile flow, the unravel length is significantly lower. But when you have physiological pulsatility, this unravel length is shorter. So we also asked her to do the study where we varied the amount of pulsatility. So this is really high pulsatility and this is low pulsatility. And what she was able to find was the minimum maximum unraveling lengths started to go down as you increase the level of pulsatility. So if you average out the unravel lengths, as you increase the pulsatility, the unravel lengths become smaller and smaller. So this is at the single molecule level. So then we hypothesized that monovalent brain factor, when it's released from endothelial cells, arterial endothelial cells, in response to the blood flow, pulsatile blood flow unravels, but when the flow stops, it refolds. It's kind of like a spring. So this partial unraveling maybe exposes the initial IMDS13 cleavage sites and not the internal IMDS13 cleavage sites. But under continuous flow, what happens is you have the sustained unraveling, exposing multiple IMDS13 cleavage sites. Maybe the monovalent brain factor produced is cleaved into low molecular weight fragments right from the start. And the pump probably has a minimal role to play in all of this. So this is what we started off as a working hypothesis. We're actually trying to quantify the unraveling lengths on endothelial cells. So the ones we did before was isolated monovalent brain factor, but this is actually looking at it at the surface of endothelial cells. We're working with Alexa Mathisis, who's the director of the high resolution imaging core, and we're able to subject these cells to pulsatile flow, continuous flow, and fix these cells while they're under flow. So you get the monovalent brain factor molecules and measure their length after the experiment is done. So this is where we're at with this. So now getting back to the monovalent brain factor production part. So this data I showed you previously, when we take these patients, we look at von Willebrand levels in circulation. Von Willebrand levels go down significantly and they stay low. And also there's increased degradation. This doesn't really relate to the production work, but there's increased degradation 1 to up to 8 months after VAD was installed. So we took our flow device, this is a smaller version of it. We subjected to pulsatile flow, continuous flow. This is just staining for von Willebrand factor. You can see that there's just based on the intensity, there's lower levels of von Willebrand factor production. And if you measure the von Willebrand factor in the circulation in the media, there's also lower. So we think pulsatile stretch plays a major role in this. So our systems apply stretch, apply pressure, apply shear at the same time. So in order to isolate one of these physical stimuli, we built a device where we can take these cells, seed them in there, and just subject them to either pulsatile stretch or not stretch them. So this is very preliminary data. Sample size is very small. I wouldn't say this is publication ready by any stretch of imagination. But at least the initial results suggest that when you stretch these cells, the stretch samples is an increase in von Willebrand factor production and a decrease in ADAMTS13 production. This is looking at the von Willebrand factor that was secreted from these cells and that's in the media. Since we don't have the shear, because these are not under flow, it's just pure stretch, we really didn't see a significant difference in what was produced from these cells. We probably need ADAMTS13 to cleave it after it's unraveled for us to see anything significant there. So this is our working hypothesis right now. So when you install a pump, a continuous flow pump, what that does is puts you under a condition where you have diminished pulsatility within your circulation. This affects both shear stress and stretch. So you go from pulsatile shear stress and pulsatile stretch to continuous shear and continuous stretch. The shear stress in particular affects angiopoietin-2 production in these endothelial cells. Angiopoietin-2 production goes up. It also contributes to increased unraveling, increased degradation of von Willebrand factor. The stretch contributes to a decrease in the production or release of von Willebrand factor. So that angiopoietin-2 in combination with degraded von Willebrand factor contributes to angiodysplasia, whereas the increased degradation and decreased production of von Willebrand factor it gets you to acquired von Willebrand syndrome. Both of these together are major risk factors for non-surgical bleeding. This is a working hypothesis. We thought we had everything figured out until we sent the grant out. And this went to a study section, which is HCBT, hemostasis, thrombosis, and blood transfusion, which is not a study section that we usually go to. And then they asked us, what about the endothelial cells in the capillaries and the venous system? The arterial system is just one part of it. If you're hypothesizing that pulsatility doesn't extend past the arterial system, how do you explain the role of these endothelial cells that are downstream of the arteries? And then we went back and we had to look at literature. And we found out that there is indeed pulsatility in the capillaries. So this is a study where they used intravenous microscopy with goat skeletal muscle and looked at capillaries within those skeletal muscle. So this is from the abstract. It says it's commonly believed that pulsatile flow generated by the pulmonary mechanism of the heart is dampened out by the time it reaches microcirculation. But they conclude that pulsatility exists in the capillary bed and then it directly correlates with pumping action of the heart. So the capillaries, if the architecture of these capillaries, single monolayer endothelial cells, opposed to the thick vessels that you see in the arteries. So even a small pulse pressure here is probably a significant difference in terms of the stretch that these capillaries observe. And then going to the venous system, this is the outward flow phasicity study. And it's widely acknowledged that there's phasic flow in the venous system, but majority of the literature suggests that it's due to respiration. So this study wanted to distinguish between cardiac and respiratory phasicity. So the purpose of the study is to determine the origin and nature of the lower limb venous Doppler flow phasicity to assess normal and respiratory waveforms. So during quiet respiration, lower limb Doppler tracing consisted of both cardiac and respiratory waveforms. And the respiratory waveforms disappeared when the patients held their breath. So the Doppler tracings continue to be multi-basic and cardiac. And the other thing to consider is venous compliance is about 10 to 20 times higher than the arterial compliance. So it should be higher, not lower. So it's very compliant vessel. So even a small change in the pulse pressure there is a significant distension of the venous vessels. So this is where we're at. I don't know how I'm doing on time. If I finished up too early, I apologize, but this is our lab, and everybody highlighted in red here, Javier and Jay are actually here. They're the ones that contributed to all of this work. And as collaborators, Dr. Kirkland helped us a lot getting this study going. He's still very active even though he's retired. And then there's Alexa and thesis, Dr. Girinar and Shane from Lehigh and Blue. And I'll stop here and I'll take any questions.
15 minutes.
Great talk, especially for the non-engineers in the room, make their job explaining it, especially with the bundle manufacturer and the atom.
Yeah.
13. Way back to the beginning is where you rolled it down to those.
Yeah.
You had a bunch of other factors that were changing the patient in your cell culture model. Is that because it's mono cell culture?
Yes, it is an isolated system, especially like TNF.
Yeah.
I don't think we have the cells to produce the TNF. So
Are you doing multiple cell culture? Especially like with the tissue on the chip, if you
Yeah.
can get multiple cell types.
right now, we're trying to keep it as simple as possible because we just want to show that we've narrowed down the location where we think it happens, which I think is the entire endothelium right now. It's not just our arterial endothelium. If we could show that this phenomenon actually is true, then it may change the way people design these ventricular assist devices, because a lot of it's focused on reducing turbulence, reducing shear stress. But if you don't address the issue of pulsatility, then regardless of how you address those other issues, you're still going to run into these problems. Yes.
Great talk.
Thank you.
A small number of patients improve on their own.
Yes.
And so, did you study any of these patients to see that the bone bilirubin factor goes up and the
So we're actually profiling the plasma from these patients. We have that information, and as and when we get patient history updates, we update our spreadsheet as well. So far, I don't think we've had enough time to make this determination. Usually, the information we get is either this patient's bleeding or this patient's passed away, but that's kind of information we get because with these devices, I think the typical post-VAD life expectancy is about 5 years now. And I don't know if that's, we haven't had any patients who improved. But we have the blood samples banked. We've done up to 6 months for 15 patients, but we haven't seen anything significant in those 15 patients. But maybe some of the other patients we've enrolled in this study will see that. And if we see that, we'll certainly go back to the records and see if there was an improvement in the condition. Yes.
Forgive me if I missed this, but the patients who tended to, do better, was there any like age factor associated with that?
So we've looked at age and we've looked at sex, and so far, at least with the 15 samples we've had, we found no correlation.
Thank you.
Yes.
So it seems like the BWF is damaged while it's tethered to the endothelial cells.
That's what we think happens when it's released. That's what's happening.
And so for patients with von Willebrand deficiency, they're treated with desmopressin, especially with prior to surgery to release membrane bound. Have you thought about trying to release it to see if it's still degraded?
So
Because it's kind of like a boat tied to the dock,
Yeah.
and when it's released.
what we think is happening is there's no aromatase deficiency in any of these patients. So aromatase is there to do, and with the bad patients, actually there's excessive unraveling, so there's increased degradation as soon as it's released.
Okay.
But I think if I understand what you're saying correctly, you're saying that in conditions where we have continuous flow, without the MPS13, maybe use that or,
Yeah, so it's released, it may not be degraded, just
yeah,
because these patients are tend to bleed,
yes,
just the ball.
okay. So we don't do anything with the patients yet.
No, but in your
all-
system.
Yeah, in our system, we could do
Yeah.
that, certainly, yeah.
Yeah.